Dr. Rahul Bhattacharyya is Director in Geriatric Services, Horizon Lifeline Multispeciality Hospital. He's a visiting consultant at Fortis, Neotia, and Divisional Railway Hospital, Howrah. He's a contributor of book chapters in various honorary journals, and is the General Secretary of West Bengal Branch of Geriatric Society of India. Sir, the floor is all yours.
Good morning, friends from Kolkata and beyond. Happy to see a fellow geriatrician in the chair. So today's topic is diabetes and dementia, the silent connection. We will try to understand the link between metabolic disease and neurodegenerative disease. Slides, please. Okay. So as you can see from my CV, I get to see a lot of dementia patients, and a majority of them are actually diabetics. Probably that's the reason why Dr. Supratik has chosen this topic for me. So let's unveil the diabetic brain. The link. Diabetes increases dementia risk by 50 to 192%. Diabetes affects cognition, memory, and brain metabolism. Insulin resistance is the culprit here, and it is central to both neurodegeneration and vascular dementia. And we will try to understand the mechanisms which helps in early detection and prevention. So I'll refer to this ERIC study. This is US data. You can see from the chart that if a person is pre-diabetic, the overall risk of developing dementia is increased by 12%. Now, come to the lower part of the cartoon, you'll see if the person remains pre-diabetic all through his life, then the actual risk is 5% increase, but if this person develops intervening diabetes at any point in time, in that case, if the age of onset of diabetes is less than 60, the risk gets increased by 192%. Whereas if the diabetes onset is more than 80 years of age, it is only 13%. So the younger the onset of diabetes, the higher is the risk of developing dementia subsequently. So this is a very recent data from South India, hospitals of South India, published this year only, and they have looked at the prevalence and the factors associated with cognitive impairment among persons with type 2 diabetes. You can see their experience is 58% patients with diabetes have shown some degree of cognitive impairment, which is huge. And if you look the age-wise distribution, those with whose age is less than 60 years, it is almost 50%, and those who are senior citizens, their incidence is almost 75%. So what are the types of damage? So all of you know that Alzheimer's is the predominant type, comprising 60 to 70% cases. Then vascular dementia. Of course, diabetes is a vasculopathy, so you can jolly well expect the patients to develop small vessel ischemic disease over time. And there is mixed dementia, which combines both AD and VAD. Now, which are the mechanisms? Of course, insulin resistance is the key mechanism, which leads to energy deficiency and neuronal dysfunction. Now, what happens in hyperinsulinemia is the excess insulin clogs the insulin-degrading enzyme. So that leaves amyloid beta uncleared, because ID is the enzyme which clears both. So if ID is clogged, then amyloid beta accumulation will increase, which leads to plaque formation and eventually neuronal toxicity. Now, chronic hyperglycemia, the mechanism is very similar for other diabetic complications. You know it all: vascular dysfunction and neuroinflammation. So finally, there will be microglial activation and cytokine activation, which damages synapses. So insulin resistance at brain, that's the core problem. and there is IRS1 dysfunction, which is a key biomarker for this brain insulin resistance. This is basically a key signaling adapter protein that connects the insulin receptor to downstream pathways, playing a crucial role in regulating glucose uptake, metabolism, and cell growth. All of you know that neurons need glucose, they need insulin. If insulin is very less, then that is problematic, and if insulin is very high, then again that is also very problematic. So insulin resistance leads to reduced glucose uptake, neural starvation, tau phosphorylation, that is very important, and we can have biomarkers, phosphorylated tau levels. So that was an excellent biomarker. The clinical correlation is with neurofibrillary tangles. And amyloid beta accumulation, all of you know about the amyloid beta 40 and 40 dose ratios, which actually clinically manifested by plaque formation. So these are the blood-based biomarkers. Neurofilament light chain is excellent biomarker, but it is seldom available outside research settings. And other inflammatory markers and this glycemic markers suggestive of insulin resistance are there, easily available. CSF biomarkers, very few labs actually do this Alzheimer disease panel, which consists of these amyloid beta ratios and phosphorylated tau and total tau. So these are extremely helpful. Let's come to the neuroimaging part. You'll find some PET scans, FDG PET scan, all of you know about that, but the amyloid and tau PET scans are important here, which can actually help in detection of early stages of Alzheimer's when they are in the stage of either mild or minimal cognitive impairment. Now, let's look at the MRI. What to look at actually? You'll have to look at the various parts of the brain which gets atrophied. This, you just look at the right side of this, the marked in green, you'll find the amygdala and the hippocampus. So one has to find the volume, whether there is atrophy. And these are the key features. Of course, if you can get a structural MRI done, that is relatively more sensitive to any changes in brain volume, and it provides a suitable method to map the current stage, and with the help of follow-up studies, you can pick up the subtle changes. But it can be very slow. There are very many flaws with MRI, so it is not that simple. It's not that straightforward. Because visual assessment is the primary method of diagnosing AD based on a brain MRI. So if you just ask the radiologists, the neuroradiologists, even in European studies, you'll find most of them are not confident. So very many scales have been developed to aid in this. These are mostly semi-quantitative scales. And all of you know that if there are not proper quantitative assessment scales, then what will happen? There will be interpersonal and intrapersonal variation, observer variation. So these scales, I'll show you just one of them. They have developed scales for parietal atrophy, especially the posterior atrophy, then the medial temporal lobe atrophy, or MTA scale, that is very popular among the neuroradiologists. But they have to ask themselves these questions. Are the vesicles widened? Is there moderate loss? Now, I think this is moderate. You don't think this is moderate. So there may be variation between our assessments. And then there is difficulty with age. Some changes may be normal for that age. Until and unless you have normative data for that, it is very difficult to label this as a pathological change. Then subtle changes are very difficult to detect with the naked eye. The smaller the changes, the harder is it to detect. So this is the MTA score I was talking about. I'm not going into the details of this, but you can jolly well make from the pictures. If there is very advanced degree of atrophy of the hippocampal area, you can guess that yes, this may be associated with greater degree of cognitive decline. So how do we extract this quantitable feature from brain MRIs? Of course, AI is the answer. This is the area where AI pitches in this era, and I'm not going into the multifold benefits of AI in medicine. You all know that. But what AI can do is they can prepare, like just growth charts in the children, AI can give you a very good normative data, and then they can report this as whether it is below 50 percentile or below 70 percentile, just like that. But you need to train the AI for that. So AI cannot do it on its own. You have to train the AI. Now, there are a lot of recent reports on this neuroradiology, the importance of this hippocampal volume measurements, and as you can see, there are very many developments there, and this can be actually indicative of even non-Alzheimer pathologies as well, with TAR-derived protein 43 and other vascular proteins as well. Now, what are the risk factors? All of you know this. Risk factors for diabetes, same here. Obesity, hypertension, CVD, frequent hypoglycemia is another very important cause for development of subsequent dementia. And of course, physical activity and chronic stress. Now, how do you prevent that? You know that exercise plays a very important role because it increases the brain-derived neurotrophic factor, which supports neural growth. And there are cognitive stimulation therapies, social engagements, gamification, that actually helps in cognitive stimulation. Medications, now what about metformin, our age-old metformin? It can actually reduce the neuroinflammation and amyloid buildup, but there are some conflicting reports, but most of those are probably due to metformin associated or induced cobalamin deficiency, which is a correctable form of dementia. Correctable, so one has to screen for cobalamin deficiency for any diabetic patient who is on long-term metformin therapy at least once in a year. Now, intranasal insulin therapy, you know that there is a lot of noise about that. It has conflicting reports again. Now, SGLT2 inhibitor helps to correct the energy imbalance, probably helpful. The best evidence as of now is with GLP-1 receptor agonist, LIRA and SEMA. Any other disease-modifying therapy, we will look into that. So this is real-world evidence, reduced risk of all-cause dementia or AD in patients with type 2 diabetes after exposure to a GLP-1 RA. So this is data from various European registries, mostly Swedish, Danish, and then Truven data as well. And there was a clue that probably GLP-1 receptor agonist helps. And in CVOTs as well, which are RCTs, GLP-1 RAs, including SEMA and LIRA, were associated with a lower risk of dementia diagnosis, almost reduced by 53%. Now, based from these clues, all of you know, if these outcome measures are not in the primary outcome measures, these are not very helpful. This is at best hypothesis generating, so you have to design a separate trial with these outcome measures as primary outcome measures, right? And that is exactly what has been done with SEMA. eVOC and eVOC Plus are two trials which is underway now, one comprising 1,855 patients with no concurrent significant small vessel pathology, and the other having 2% concurrent significant small vessel pathology. And there are some other mechanism of action sub-study and of eVOC Plus that will help to assess the effect of oral SEMA on CSF biomarkers. And transcriptomic study will investigate the changes in immune cell signature in both in CSF as well as in blood. So genetic studies as well. It will be done in 40 countries, 566 sites in total, and we will have to wait for the results before jumping into conclusion. And this is another very important molecule which has recently got US FDA approval for treatment for these dementia patients. Lecanemab is a humanized IgG1 monoclonal antibody, and it has got clearance first on the basis of emergency approval and then regular approval within 6 months. This preferentially targets protofibrils, not just plaques. So you can see from the cartoon, it binds to soluble amyloid beta protofibrils, promoting clearance and amyloid plaque reduction. So it's probably a milestone drug for early Alzheimer's, offering modest but real disease modifying potential. And there are side effects in the form of signal intensities, hemorrhages, small hemorrhages, and this is the Clarity AD trial, again showing the same thing. So to conclude, these patients with early Alzheimer's, they can actually benefit in the form of less decline on measures of cognition and function, and to the tune of 27%. So there are other trials. For the sake of time, I'll not go into that. So these are the future directions in research. Let's sum up here. Approach, use first clinical assessment, then history, cognitive test. You have to rule out the treatable cause. At step 2, assess the biomarkers. Step 3, imaging and PET scans, MRIs, and then you classify the dementia types, then manage accordingly and follow up every 6 to 12 months. So diabetes significantly increases dementia risk. Brain IR is the major underlying pathology. The biomarkers are there to help us in the early detection. Diet, exercise, and blood sugar control, of course, is of pivotal importance. And new treatments are there which target the brain insulin resistance. We will have to wait for the eVOC and eVOC Plus trial for semaglutide benefits. Lecanemab, prohibitively expensive at this point of time, but has got a disease-modifying potential. However, given cost, side effects, and monitoring needs, prevention through metabolic control remains more accessible and impactful at the population level. Thank you. Which one, sir? Monoclonal antibody? No, no, sir. So in the US last year, the annual cost, it is an IV drug which needs to be given every 15 days in the form of an IV infusion. And the annual cost was somewhere between $26,000 to $40,000. Please, Mike, please, I can't hear you properly.
My question is this, have you any idea regarding the prevention of dementia in case of non-diabetic patient having MMSA score of significant level? Can we use semaglutide in those cases?
We cannot conclude right now. So there are, I have shown you eVOC and eVOC Plus. The trial is underway. So we have some certain clues that probably the molecule helps. It actually improves the blood-brain barrier integrity. And of course, it plays, this is the only anti-diabetic agent which actually helps beyond diabetes, acts at the level of the brain. So, but we cannot say for sure until the results are out.
Okay, thank you.
Yes. Yes, and there is a subset. I'll have to look at the details again about the eVOC. I'll share with you the whole eVOC data, the design, because yes. Any other question?
Any other questions from the audience? Thank you so very much for this wonderful lecture. It was quite a knowledge enhancer for all of us. Thank you so very much, Dr. Bhattacharyya.
Thank you.